what I'm going to do is show you kind of what we look at as in terms of issues associated with patients and why we're looking at these things. So the reality is that in the United States, there's very few patients that you're going to run across that do not have significant metabolic issues. 93% of Americans are metabolically unhealthy. That means 93% are sick. 84% of them don't even know that they're pre-diabetic. And that's a big number. And of the patients that come to you for medical care, it turns out that 99% of them, patients that actively seek medical care, are metabolically ill. And these can be generalized symptoms: fatigue, brain fog, depression, anxiety, lack of exercise endurance, erectile dysfunction, chronic pain, increased appetite, slight obesity, viscerogenic obesity. It could be muscle loss. And so 99% of the patients that are actively seeking medical care are going to be patients that have metabolic dysfunction. And that's your target zone, because you can do something with that. There's been a massive change. Only 15% of people used to be metabolically ill. And now it's almost every American that we have. The typical measures that we look at is glucose, and we look at hemoglobin A1C and we go, hey, you got a high hemoglobin A1C and you got a problem. That was what we used to look at. It turns out that that's wrong, because the hemoglobin A1C underestimates the likelihood of prediabetes and insulin resistance by 75%. So you can't rely upon that. The number one cause of liver transplantation in the United States today is fatty liver. It's the number one cause. And you can actually fix it 60, 70% of the time in 3 to 5 days. And you can have a massive outcome change. And if you catch it early enough, before the FIB-4 score goes up, before they start to get fibrosis and permanent damage, you've actually saved that patient a lifetime of pain. It's a high FIB-4 score is also one of the top 2 causes of cognitive impairment. In fact, it's the differential diagnosis for Alzheimer's. About 40% of patients that we're diagnosing with Alzheimer's actually don't have Alzheimer's when we get to autopsy. Turns out that they had a high FIB-4 score and they had cognitive impairment, and we would have picked it up had we done a workup of their liver. So normally we use SGOT, SGPT, but that turns out that's the wrong test. Their issue is that their nitric oxide production is low, so their plethysmography would be off, and a enzyme called gamma-glutamyl transferase, GGT, is high. And if the GGT is high in the presence of insulin resistance with an LPIR that's high, and in the presence of abnormal nitric oxide production, you have a major issue, because that patient is edging toward having severe cognitive impairment, and they're going to have complications. So the vast majority of the United States is overweight or obese. And so one of and this graph is not to tell you that. This graph is just to show you the percentages of obese patients with a BMI greater than 30 in different states. The vast majority of the United States is significant, but this isn't the graph that's going to show you that. What this graph is actually to show you something else. And that's just for you to keep in mind that normal weight's 18.5 to 25 on the BMI. Over 25 is considered overweight, obese, class 2 obesity, or class 3 obesity. Anything up here is a problem. And that's going to be at least 93% of your population is going to have metabolic resistance in general. And at those seeking care, it'll be 99%. And even in the patients who are underweight, they may have insulin resistance, but be sarcopenically wasted. And so that's something else that you have to keep in mind. And inside the normal healthy population, there's a variance based upon their ethnicity. So if they're Asian, this number for being healthy, normal weight, is actually like much lower. It's about 2 to 3 points lower. So the point of that graph is just to reframe it so that you can realize that very few of your patients are going to fall normal. So what's happened over time? This is what 2000 looked like. The number of people that were obese, year 2000. This is what 2019 looked like. It's a dramatic change. This is what we're projecting at 2030. And in fact, the people, almost every state will have more than 20% of the population obese. The only few exception might be Colorado by 2030. Otherwise, every other state will be massively overweight. 73.6% of the current population is overweight or obese. And that's just direct measurement. And that's based off practically every single study that we've looked at. Now, it used to be that lifespan in the United States was steadily going up. It was steadily going up. It was steadily going up. Kind of plateaued. It started plateauing in 2010, and then suddenly it dropped. What happened here? COVID. But it's not just the COVID. It's not because we had a massive number of deaths. We had some, but this really reflects other factors. And what this reflects is the deaths associated with COVID that were increased by metabolic dysfunction. Patients that were healthy, that were not overweight, that did not have insulin resistance, very few of them had significant complications. Very few had thromboembolism. This factor right here is really metabolic dysfunction. Now, lifespan is going back up, but we've lost 2 decades of progress in lifespan and life expectancy, and that's a big decrease. If you look at care seeking by patients, and I think this is relevant because people always ask me, well, I'm not the primary care, so why should I chase this? Well, it turns out the vast majority of patients no longer have a primary care. And it could be as high as 60% of them no longer have a primary care. Most of them are refugees from their primary care. They can't get in. And so they're going to go to any port in the storm. And if they're seeking medical care at a specialist, if they're seeking medical care at a location that's going to treat their pain, if they're seeking medical care at the urgent care, that's their care. There's not somebody else that they're going to. And if you look prospectively, the number of primary care physicians is rapidly declining. The number of primary care providers is rapidly declining, including nurse practitioners and specialists. They're all declining, and we're having a massive issue with the ability to care for these patients. All of this is to bring us to the nexus of why are we doing this and what are we doing? 3 out of 4 physicians now that are primary care are employed by hospitals or corporate entities. They're timed to see their patients, so they're no longer able to actually take care of these patients effectively, and they're practicing purely by algorithm with a response of, this hurts, go see this guy. This is this, go do that. But they're not actually taking care of their patient, and they're getting stuck. What are we doing? Why are we doing what we're doing? Well, the vast majority of disease processes, high blood pressure, heart disease, diabetes, it's all preceded by metabolic disorder. It's preceded well in advance of this. 2/3 of the US healthcare expenditure is spent because of metabolic dysfunction. Probably 60 to 70% of all cancers are metabolic. 75% of all psychiatric conditions are metabolic. In fact, I would tell you that the vast majority of orthopedic issues, polyjoint arthralgias, the requirement for hip replacement or knee replacement, it's primarily a metabolic issue. It's not load bearing. So one of the main drivers of population decline, new kids being born, is impotence. That's a metabolic issue. Our sperm counts are going down. That's a metabolic issue. It's too much plastic, and it's a change in microbiome, and it's also a change in nitric oxide production. So these are all metabolic issues. And if you look deeper into this, what we've done with Misura is created tools, just like you would have an ultrasound, just like you would have an EKG, just like you'd have a stethoscope. We've created tools to help you measure the metabolic parameters so that you can appropriately treat. If you look at psych issues, 75% of schizophrenia is a metabolic issue. And if you fix that metabolic issue, these people stop hearing voices. The vast majority, 85 to 90% of anxiety is metabolic. It's a GABA aminobutyric acid issue, and it's a change in heart rate variability. In fact, the vast majority of patients who have psychiatric disorder are obese. We've always known that Alzheimer's is really considered type 3 diabetes. But did you know that almost every schizophrenic patient you have either starts off as having a metabolic issue to start with, or the medications that they're taking induce a metabolic issue and they've got problems. Right now, none of us want to use an opiate because we know that opiates aren't necessarily a great solution for pain long term. And so there's been a shift, and more patients are being given benzodiazepines. But benzodiazepines independently are causing some problems, and they're causing just as much addiction, practically speaking, as anything else. And so those are significant issues. If you look at orthopedics, and you wouldn't really think of orthopedics as being the hotbed of metabolism, but there's great papers published just in the last 3 to 5 months that show that the metabolic changes in the joints precede the X-ray changes by 8 years. And you can identify which joint's going to go bad 8 years before it happens. And if you look at those biomarkers and you come up with what the biomarkers are, which they've done, you have a high degree of assurance that you know exactly which joint is going to get worse. It has nothing to do with load bearing. Certainly they change their load bearing after they get their structural changes, but those metabolic issues preceded. And even when you fix that one joint, the other joints in the body start to hurt, and the patient doesn't do well because of a variety of other reasons. No matter how good their surgical technique is, these patients are still having massive issues, and they still have high degrees of postoperative pain. They drop their socioeconomic status. They end up with poor social support networks. And so all of these issues are part of lifestyle. And what we're doing is we're measuring the problem, and then we're implementing a lifestyle coaching program to help them, whether they're a primary care patient, a psychiatric patient, a pain patient, an orthopedic patient, a GI patient. It's all the same common pathway. And that's what we're pushing towards to get them situated. So you guys have some specific questions, and I want to go over those specific questions, and I want to go over the process of how we get to where we get to. So initially we'll put a person in your office that will do age, gender, race, height, weight measurements, calculated BMI, calculate an abdominal girth, get the blood pressure, heart rate, and oxstat. These are the bare bones physical parameters that we need. We'll take those data points and enter them into your EMR. While we're doing that, we'll be discussing with the patient what the risk factors for metabolic syndrome are. If they're positive in any way or shape or form, suggestive that they have any risk for metabolic dysfunction, then we'll go forward to our next step. And that would be anything with a BMI that's high, anything with nerve pain, joint pain, fatigue. Are they at risk for opiate use? Do they have anxiety? Do they have high blood pressure? Any of these factors comes up positive on the review of systems, and then we'll go on to the next step. The next step is a little bit more detailed review of systems. This whole thing takes about 3.5 minutes. We're educating the patient while we're doing this the entire time, explaining to them why metabolics is so important and how does it impact all of their organ systems, so that we're giving them some pieces of education. The reason why we're doing that is because when you're doing lifestyle coaching, and you have to be able to go back to the patient and have a discussion. And that discussion may have to happen 20 to 30 times in a year in order for that patient to absorb the information. So we're giving it to them right up front and then reinforcing it through the process. All this. The testing that we do, the specific testing, we're looking at insulin level. And the reason why we're looking at insulin level is that most people know that you can measure it, but they don't know what it means. They don't understand what it should be. If your insulin level is greater than 10, you have a problem. Most of your patients you'll find have an insulin level of 20 to 100. If your hemoglobin A1C is normal, that doesn't mean much to me. If your hemoglobin A1C is high, we have a problem. But a hemoglobin A1C of 5.4 in the presence of a high insulin doesn't tell me much, because what it tells me is the pancreas is still putting out insulin and it's overwhelming the bloodstream with insulin and taking the circulating sugar and storing it as fat in the liver. And that doesn't do much good, because that patient eventually is going to become insulin resistant. And when they do become insulin resistant, the insulin level will keep climbing, and eventually the beta cell will fatigue, and then the hemoglobin A1C will go up. The hemoglobin A1C won't go up till the amount of glucose exceeds the production capacity of the pancreas for insulin. And insulin itself is a fat storage hormone. Insulin is the problem in type 2 diabetes. In type 1, insulin is the problem because you don't produce any. In type 2, you produce too much until you get to beta cell fatigue, and then you can't keep up. Well, as you're producing that insulin, you're storing every bit of carbohydrate that you take and 30% of the protein that you take in and turning it into sugar in your liver. And it's the storage of sugar in your liver that accelerates the insulin resistance. And that's a major complication. We measure things like fructosamine. You'll be shocked because hemoglobin A1C measures glucose bonded to the red cell. Fructosamine measures fructose bonded. The fructose comes from high fructose corn syrup typically, and it's the fructose that's more addictive in the brain than the glucose is. And so you'll find patients that have normal hemoglobin A1C. Insulin is not a driver of fructose. In fact, the body doesn't produce insulin to fructose. And if you have high fructose, normal insulin, normal hemoglobin A1C, you'll get very high uric acids. And fructose itself independently causes severe damage in the brain. And so that's why we look at fructosamine instead of just looking at hemoglobin A1C. We'll be looking at C-peptide. We want to know, let's say that the insulin level is low, but the C-peptide is moderate. There's a disconnect between the breakdown of insulin, because for every molecule of insulin you'll be separating it from a molecule of C-peptide. And if your C-peptide is abnormal in comparison to insulin, we got a problem. If the patient is on insulin and their C-peptide is high, that means that their body's producing a ton of insulin innately as well. And that means that's a ripe patient to be able to get off of their insulin. Those patients that have high C-peptide that are on insulin, we can usually wean them off their insulin in a matter of a few weeks. ANA, rheumatoid factor, HSCRP, those are pretty standardized, except that most docs don't realize, and most providers don't realize, that the ANA is a marker of liver leaching material. It's leaching, the cells are being destroyed slowly. The homocysteine closely correlates with Alzheimer's. It closely correlates with glutathione rescue, and it closely correlates with the progression into Alzheimer's. And when you combine it with genetic testing for ApoE4, if it's homozygous, you have a 95% chance of becoming Alzheimer's. So it's something that we want to look at. GGT is a more sensitive indicator of liver function than is OT and PT. We look at NMR lipids, and because the LDL-C I don't know if you remember back here in this slide on metabolic syndrome, right up here, high waist circumference, high fasting glucose, high triglyceride, low HDL cholesterol, high blood pressure. There's nothing about LDL-C in here. It's because metabolic syndrome has no correlation to LDL-C. And so the LDL-C doesn't mean much to us, but it strongly correlates to LDL-P, which most people don't get measured. And LDL-P is an inflammatory biomarker. It tells us how badly your blood vessels are going to be packed with cholesterol forming spicules, and the likelihood that your linoleic acid is going to be oxidized or not. We look at an omega-3 and 6 ratio. We want to see how much vegetable oil omega-6 there is and how much fish oil there is omega-3. We want to look at that closely, and actually it's supposed to be omega-6 to 3. And we want to also look at how much of your LDL that's circulating, your linoleic acid, is oxidized. You're going to find that you have patients that eat a lot of fried food where they never change the oil in the fryer. And those patients are going to have very high oxidized LDL. They're also, when we get the data from all this, we'll be able to enter it into the Mazura protocol. It'll give you a 5-year outcome on the likelihood of that patient dying. So I had a patient yesterday, literally like last night. The patient came in, and after we got all this, her oxidized LDL was about 160, which is really high. And her Mazura testing came back, and her percentage was 31%. And she's young. She was in her 40s. And incidentally, we also discovered that she was diabetic, which she didn't know. And she had about a 40 to 50% decline in renal function. Her likelihood of survival for 5 years is about 1 chance in 5 to 1 chance in 10. Not 1 chance in 5,000, 1 chance in 5. So we have to make an intervention, otherwise we're going to be in trouble. If your percentage is 80% or greater, you're going to have 1 chance in 55,000 of dying in the next 5 years. Hers was 1 chance in 5. And so that's somebody that we can intervene on very quickly because we have the data. We've got the blood results, and we've got the biologic testing that we do with the Mazura. We measure prolactin. A lot of these patients will have hormone dysfunction, and prolactin is actually an inhibitory hormone. It will go up as everything else goes down. So if your free T3, if your FSH, if your LH is going down and you're not producing, your prolactin usually will be going up. It's not just a marker of brain injury. It's a marker of brain injury traumatically, but it's also a marker of brain senescence. And that's what we're looking at. We look at free and total level testosterone on men. We look at free and total on women as well. We don't obviously look at PSA on women, and we will occasionally look at sex hormone binding globulin. It really depends. We're going to get that calculated no matter what, so we'll be able to back into it. But if your sex hormone binding globulin is high, and even if your total testosterone is high, it doesn't mean anything. Your free level is low. And so if you've got the free level and the total, you may not need to do the sex hormone binding globulin. We look at uric acid. Uric acid is more a derivative of fructose than anything else, but you also see high uric acid levels in artificial sweeteners. And it may be more of a function even of insulin and hyperinsulinemia, which causes uric acid retention. And so gout is more likely not just an arthritis, it's a metabolic problem primarily. We look at B6, B12, and vitamin D. These are the base tests that we look for in our metabolic panel. And then if they have a family history of neurodegenerative, if they have a family history of Alzheimer's, if they're missing things, we might be ordering a neurodegenerative test. We might be ordering a thyroid panel genetic only if they have a family history of thyroid cancer. I'm always surprised about that question because so many of our patients have it. Autoimmune panel is usually something that we'll order if the patient has leaky gut, which will turn out to be 30% of your patients. Cancer genomics are reserved if somebody has a direct family member that has a history of cancer. A lot of the patients have had family members with urogenital cancers or breast cancer or testicular cancer. Most of them have never had a BRCA gene done. Most of them have never had a cancer genomics done. Cardiopulmonary panels, we don't really order very often. Eye disorder panels, which are genomic panels, we don't order very often. Now, there are exceptions to that. If you run a practice and you see a lot of optic atrophy, and if, for example, we have a doc that predominantly takes care of Jewish patients, and they have a very large population of Jewish patients. And I'm always shocked at how many patients have inherited eye disorders and Leber's optic atrophy and a few of the others. Pulmonary panels are rare to run. The most common, obviously, is neurodegenerative, thyroid, and autoimmune. So that's the general pathway and the path flow. As in terms of therapeutic monitoring versus urine tox. So normally, if you have a patient on a narcotic, or benzodiazepine, or some psychotrope, you want to know if it's actually in their system. And so we typically will order urine tox. But there are times that you have patients that say, hey, I take my drugs like I'm supposed to, but I don't know why, but they just don't seem to work. Well, it could be because things aren't working. Maybe they can't methylate, or it could be that they're not getting the right meds and they just haven't taken them like they're supposed to. So sometimes, based upon what we're getting from the history, we may be ordering pharmacogenomic or therapeutic monitoring. If you run a practice that has a lot of nursing home patients, we often will recommend, hey, you should at least screen your urine toxicology, your urine for bacteria about once a month. The number one cause of hospitalization for a nursing home patient is urosepsis. And you can pick it up, and 65% of them are positive and they don't even know it. And if you use a broad spectrum antibiotic to treat them, you actually will cause a bacterial overgrowth, and you'll actually put them in the hospital by doing that. And so you want to be very particular. One, identify by PCR rather than by growing it out. Growing it out takes a week, and a PCR only takes 24 to 48 hours. And so you want to be very specific with what you do treat, if you treat it. The same thing goes for a lot of my patients that are in nursing homes that I wouldn't normally test them because they're in a nursing home. Why would I test them for drugs of diversion? And you'll find out that there's a lot of trade going on at nursing homes. The number one growth of STDs in the United States is in nursing homes. The number one growth of syphilis in the United States is in nursing homes. So if you do any number of nursing homes, we're almost always doing an initial screen for STDs. And so we're looking at those factors, because what we're trying to do is get a correlation and then bring our metabolic testing right next to it so that we can come up with a long-term lifestyle coaching program. So that's kind of that's why we do what we do. And this is kind of the first module in how we do and why we do. The rest of this is meant for you guys to ask me questions and kind of poke holes and ask me what you need to know so that we can have you convey additional information. So what do you got?
Okay, thank you for that. That was very interesting and very, very informative. It answered a lot of my questions right off the bat. So I see that when a patient comes in, essentially, if they are saying they're positive for any of those initial screening questions, we can go and order like metabolic screening at our discretion, correct?
Yeah. And you're going to find that's positive. If they've come to your clinic and they have any symptoms, it's 99%.
Okay.
But if you took the general population, like you went to I wouldn't say go to Walmart, but let's say you went to a regular grocery store, 93%. Mm-hmm. If you go to Walmart, it's very disproportionate. It's actually, and so because Walmart's the largest distributor of sugar sweetened beverages in the United States.
Yeah. So do you have